Hi, I'm Dr. Joe Rogers, President and CEO of the Texas Heart Institute, and I'm joined here today by Dr. Joe Galati, who's one of a few hepatologists in Houston, Texas, and is with Liver Specialists of Texas. And Dr. Galati's just given an outstanding grand rounds talking about the overlap between fatty liver disease and heart disease. And I thought we would just take a few minutes and explore a couple of other issues. You and I have a long history. We're very interested in sort of metabolic diseases and the impact of metabolic diseases on our respective organ systems. And it's been a lot of fun to think about how the worlds of liver disease and heart disease overlap. So Joe, we're really happy to have you here today.
Yeah. Well, I thank you, Joe, for inviting me, and an honor to be at the Texas Heart Institute as a hepatologist trying to share what we do every day. But I do think that when you look closely at a condition like fatty liver disease and the diabetes and the metabolic syndrome, there's a tremendous amount of overlap of the cardiac patient that maybe is not quite being fully addressed. These patients are getting the care they need, but considering the amount of fatty liver disease that there is and the morbidity and mortality, I believe we have to realign how we look at this disease between the two disciplines.
Now, there are some people that will watch this segment but won't have watched your full grand rounds. I would encourage people to go back and watch that grand rounds because it was really practical. I think you laid out a beautiful case for this overlap. But for those who may not have the time to go back and watch your full lecture, the people who are watching this segment now will go into their offices later today or early next week, and they'll see this patient population that has metabolic syndrome.
Right.
And what are the things that they should be doing to sort of consider whether or not the patient may also have fatty liver disease? And I think the other thing that you may want to highlight in the context of that question is, what are the negative health implications for the patients if they do have fatty liver disease?
Right. So I think at the highest level, it is the realization that this is not a benign disease, where you're right. The primary care, the specialist will see patients with fatty liver, and they may see normal liver enzymes. The truth of the matter is the liver enzymes are the least important thing. So they have a fatty liver, they identify it, but then they sort of say in their head, well, your liver numbers are okay, you look okay, your stomach doesn't hurt, I'll give a pass. And unfortunately, that is a lost opportunity. What I said in the talk, which is, I think, key, is that even without fibrosis or advanced liver disease, the mere fact that they have a fatty liver puts them at risk for cardiovascular disease, malignancies, and all sorts of other complications. All-cause mortality is up. And so they first have to look and say, forget about the liver enzymes. They have fatty liver, risk stratify them from a cardiac standpoint, and then realize that they have to aggressively manage the cardiovascular risks, the hyperlipidemia, the hypertension, the obesity, the prediabetes or the diabetes, and be, in a sense, really driven to take care of these people.
So what are the triggers, Joe, to send someone on for further evaluation? So our clinics are packed with people who have the risk factors that you just described.
Right.
What are the triggers for us, assuming that most of us are not going to go out and start doing fibro scans in the office? What are the triggers that we should use to refer a patient on to either a gastroenterologist or a hepatologist?
Right. The easiest thing to really decide low risk or high risk would be this test I talked about. It's called a FIB-4, FIB-4. There's an app on your computer. You just need to enter a few chemistries, and you'll see right away high risk or low risk for fibrosis. That's one thing. Lifestyle modifications from a liver standpoint, discontinuing alcohol. That would be one thing. The other thing would be if you have an ultrasound and you see portal hypertension, an enlarged spleen, a low platelet count, a liver that appears somewhat nodular on the surface, you know that this person is getting to more advanced disease. And so if they were just to do that, the hundreds of thousands of people that would be put into the right place would be excellent. That would be, I think, the easiest thing to do.
So, Joe, what about managing the risk factors that we've talked about today? The lipids, the diabetes, the hypertension. Do we know that aggressive management of those risk factors influences the likelihood of development of fatty liver disease?
It does. And so at one end, we know that with weight loss, with exercise, with control of lipids, with control of blood sugar, again, even that pre-diabetic that has just a touch of diabetes, as people like to say, fatty liver is reversible. Losing 3 to 5% of their body weight, 10% can reverse fibrosis, and you can impact the natural history of this disease. And what I see all too often is that the natural history truly runs its natural history course, where 5-10 years ago, they were identified with a fatty liver, and for one reason or another, nothing was really done, and they present with advanced liver disease. So the aggressive treatment of these underlying problems, statins are safe, no need to stop. Most of the medicines for type 2 diabetes are going to be safe. Most medicines for hypertension are safe. Diet, exercise. It's almost too easy. It's almost too easy to say, just aggressively treat these patients, but there's hesitation. Once their liver is thrown into the mix, people shy away and hesitate instead of hitting the gas and going down the green light.
So many of us will immediately turn toward pharmacologic therapy because that's the way we are trained, and largely it's easier for us than trying to create a lifestyle modification regimen for people. And it's frankly, some of the things that we would want them to do are very difficult. So the non-pharmacologic approaches that you're recommending, you suggested some amount of exercise, restriction of alcohol intake, and you recommended some relatively specific diets. I wonder if you would walk through what that other portfolio of therapies might be.
Well, you know, it's with regard to diet, and we've talked about this 100 times, the diet of the week, the book of the week, what should, you know, the influencer online diet. But I would say dollar for dollar, the Mediterranean diet is going to be the best all around. Lots of fruit, lots of vegetables, citrus, nuts, beans, a little bit of wine.
Lean meats.
Lean meats
Yep.
is going to be the way. And I would think that would be the simplest thing. Instead of trying to remember all of these other things, just say to yourself, Mediterranean diet is the way to go. Exercise certainly is beneficial. I would say any form of exercise is going to be good, but the studies have shown vigorous, intensive exercise is better than more pedestrian type of exercise.
Yeah. And you made an interesting comment during Grand Rounds about the importance of the microbiome.
Right.
And I think many of us have become increasingly interested in the microbiome's role in a variety of different diseases. It certainly plays a role in weight. It certainly plays a role in cardiovascular disease. You're thinking now about a couple things. Is there a way to understand it practically today? And is there an intervention that you think might ultimately be beneficial to our patients?
You know, one point here, there are a number of commercial kits available globally where you could send some stool and you will get a microbiome profile. Most experts in this field say, don't do that. There's too much error and it's more confusing. So don't try to do your own stool testing at home. That's number one. But number two, if you look at what we just said about the diet, the reason our microbiome has turned upside down is due to the processed foods, increased fat in the diet. What is the remedy? A Mediterranean diet. We know that fiber, if you look at these prebiotics, it's basically, prebiotics, people get confused, prebiotics, probiotics, but the prebiotics are going to basically be real food with fiber. You have to feed the bacteria in our gut fiber. And so if you go to more fiber, which means you're hopefully eliminating foods that are low in fiber, the processed foods, that is beneficial. Drinking coffee, believe it or not, 3 cups a day will help optimize your microbiome. The elimination of artificial flavors. That is not in the Mediterranean diet. So if you go to a diet that is whole food, plant-based, you'll be nourishing your microbiome, which we know we could turn around. Fecal transplant is on the horizon. There are people doing it now. That is something to stay tuned for. And then the role of probiotics. Here again, there are 1,000,001 probiotics that you could buy online or at the store. Again, the quality of these, we just don't know. There are a handful that are, I would say, close to being pharmaceutical grade that may be beneficial, but if you start with a whole food plant-based diet, it'll help your heart, your liver, lose weight, and feel better. So,
Joe, I can't thank you enough for coming. Great grand rounds today and a fantastic talk. You're welcome back anytime.
Well, thank you. Really do appreciate it.
Thanks very much.